Hello and welcome to Clinical Path. Today's topic is the anatomy of the heart, specifically including gross anatomy down to the level of tissue. Now you notice that this is titled structure, and I think that's a better way to think of this than just using the term anatomy, which conjures up memories of dissecting cadavers. Because every time you think about the anatomy of any given organ, in this case the heart, you really should go from the regional anatomy of the heart, in this case the thorax for the heart, because organs interact with the other organs around them. And from that then you should imagine, what do I see when I look at the surface of an organ? Because that's a good way to think about the blood supply of the heart. And then the internal structures, down to the level of tissue, which is the architecture of an organ, the individual cells and how they are designed to fulfill their function, the internal structures of the cell or ultrastructure, which is made of our proteins, and that's made by the DNA. So the ability to go from the regional anatomy through to the protein structure of a cell is the essential platform on which we're going to build function and disease. So when we talk about the regional anatomy of the heart, we're really talking about the thorax. And there are two standard imaging views that are good ways of thinking about this. The first is going to be the chest x-ray. In this case, we have a PA or back to front image. And when you look at this image, you should see the heart in relation to the structures around it. And look, you can just draw it. So when I say heart, this is the image I have in my mind. And when we do this, then we can look at the key areas that matter. And the first is up here in our superior mediastinum. And a good way to think about the superior mediastinum is to look at a lateral view of the chest x-ray. So let's draw a sternum. There's my manubrium to body, and there's my angle of Louis. And then draw in your thoracic vertebrae, 1, 2, 3, 4, and then so on down to T12. Because when we do that, we can see the angle of Louis to T4 is the definition of the superior mediastinum. Most posteriorly, that's going to be my esophagus. In front of that is going to be the trachea, which bifurcates right at the level of the junction of the superior and inferior mediastinum. In front of that is going to be along the superior extending into the anterior is going to be my thymus. And then also found here in the superior mediastinum are going to be lymph nodes. So when we talk about what are the important diseases here, we can see that the thymus, that's going to be my thymoma. And if it secretes anti-acetylcholinesterase receptor antibodies, that would give me myasthenia gravis and weakness. When we talk about lymph nodes, we're talking about lymphoma, especially nodular sclerosing Hodgkin's disease. And if that secretes abundant cytokines, that's going to give me the B symptoms of fever, night sweats, and weight loss. But what if they don't secrete any proteins? Then we're going to be talking about the symptoms of mass. And now we can see that pressing against the esophagus will give us dysphagia, and pressing against the trachea will give us dyspnea. Next down is going to be our ascending aorta and arch, and that's going to give us the differential diagnosis of aneurysm and dissection, which will be the tearing chest pain radiating into the back. Where the lungs insert, those are the hyla of the lung, and they're very important because in them we're going to find mostly is going to be lymph nodes. And if we have unilateral lymphadenopathy, that's going to be unilateral diseases like cancer and infections like TB. But if it's bilateral, that implies a systemic lymphadenopathy, and that's going to be systemic diseases, so for example, sarcoidosis. When we talk about the right side of the heart, we understand that most of the time right ventricular hypertrophy follows left ventricular hypertrophy. But what about isolated right ventricular hypertrophy? So when we talk about only the right ventricle, now we're talking about the diseases that are going to involve pulmonary artery hypertension. So that's going to be diseases like cor pulmonale from lung disease and recurrent pulmonary embolic phenomena from hypercoagulable states. Next, always think about our pleural effusions down here at our costophrenic angle. Effusions are one of the fundamentally really important differentials of medicine, with transudates from congestive heart failure and exudates from inflation and neoplasm. Next, we want to take a look at the cardiac silhouette. Because if the cardiac silhouette is more than 50% of the thoracic diameter, that's going to equal cardiomegaly. Regional anatomy of the heart, start with your chest x-ray, and you can see there are going to be 6 important regions with these well-defined disease groups based on anatomy. The second great way to think about the thorax is to think about the T6 transverse section of a CAT scan. And in your mind's eye, you can just draw it. So look at this. I can just draw this T6 image. And onto that, you can see then we can draw in the cell wall. There's my sternum. And then these are the angles of the ribs. Into this, we can add our vertebral body. And then we can add in the heart. And because we're at T6, remember, this is going to be the bullseye view of the aorta. And we can see that right there. Add in the all-important left ventricle, the descending aorta, and our esophagus in front of vertebral body. And now we can talk about the important diseases that we have to think, which we use as our differential diagnosis here of chest pain. So the first part of the differential diagnosis of chest pain is up here, which is going to be my chest wall. And a really good way of thinking about the chest wall is going to be costochondritis. The cartilage that joins the ribs to the sternum is a weak point, and anytime you do heavy lifting or heavy exercise, that weak cartilage can undergo stress, inflammation, and hurt. The second structure to think of is going to be the pleura. The pleura wraps all the way around the heart, so we can see disease of the pleura, specifically here pleuritis, as a differential of chest pain. The heart is wrapped in the pericardium, and that then becomes our third organ from this mental image. We then come to the all-important left ventricle, and that's going to be responsible then for angina. The ascending aorta is the site of aneurysms and dissection, and that then becomes part of our differential. And then last but not least is our esophagus here in the posterior area. So when you're in the emergency room and you get a patient presenting with chest pain, that's how you do your differential diagnosis. And it's important at this time to think through, as you go through this differential diagnosis, what are the criteria that you're going to use to rule in or rule out any of these entities. So if you have costochondritis, you're going to go to the physical exam, and when you push on that inflamed cartilage, it hurts, and that's how you make the diagnosis. When we talk about the pleura, again with pleuritis, it's going to be an acute fibrinous pleuritis. And so again, we're going to use the physical exam because there's going to be a rub. Pericarditis is also going to be an acute fibrinous pericarditis. So again, on physical exam, we're going to have a rub. Left ventricle, this is going to be angina. And so we're going to do both the EKG, because the ST segment is very useful in diagnosing ischemic changes, and we're going to use troponins as evidence of necrosis. When we're looking for aneurysm, this is going to be a dissecting aneurysm diagnosed by imaging. An esophagus, which is mostly going to be esophagitis of GERD, but you can also have spasm, this is going to be diagnosed by endoscopy. So we can see this isn't just an exercise of learning lists. This is going to be a really important way to do a working differential in one of the commonest problems that you're going to see in acute care medicine. The surface anatomy is a very good way to think about the blood supply to the heart. So when you see a standard picture like this, it's actually really useful to draw it out yourself. So you can draw out the right border here, you can come across and draw the ventricle here, and then you can see that we've got the aorta coming off here with the great vessels. We can start with our most important, which is going to be our left main. It's responsible for the majority of the heart, say 60% of the left ventricle. So anytime you get an occlusion there, you really aren't going to manipulate it unless you have emergent surgery to back you up in case it occludes. Coming off then the left main is going to be our left circumflex. And the left circumflex most of the time just does the left lateral wall, but remember 20% of the time it's going to be dominant, which means it is going to supply the posterior third of the septum. Then we come to the all-important main branch here, which is going to be our left anterior descending artery. It does the apex, and it does the anterior 2/3 of the septum. Branches of this tend to be called diagonal branches, but they're variable, so they aren't really given specific names. Compare that now over here on the right side. When we talk about the right coronary artery, The first branch is going to be the sinoatrial node branch. So anytime we get a sick sinus syndrome, the ischemia is going to almost invariably be in the right coronary artery. As it comes down, then we can see that its branches aren't called diagonal, they tend to be called marginal, but again they're too variable to be given a dedicated name. 80% of the time, the right is going to be dominant. That means that it's going to go to the back of the heart, where it's going to supply most of the posterior wall, including the AV node, and then again it's going to do the posterior 1/3 of the septum. So surface anatomy of the heart is a great way to think about blood supply. The next important image here is to imagine where the esophagus runs, because the esophagus is going to allow us to do echocardiography with minimal amounts of tissue interference. And so that's how we're going to think now about the internal structure of the heart. There are three great views that we do, and it's how we're always going to talk about in reference to heart. And the first of these is one that we've already seen, which is going to be at the level of T6. Imagine that we have a cephalad view, so this is the right side. We're looking up at the brain, and we always start then with our bullseye aorta, because now we can see anteriorly is going to be our right ventricle, right side is going to be our right atrium, posteriorly is going to be our left atrium, and then over here on the left side, that's going to be our left ventricle. The tricuspid aortic valve we can see is going to have three leaflets. Here is going to be the right coronary artery. Here is going to be the left main. And then here is going to be our non-coronary cusp. So that's a useful view and one commonly you're going to see for the atrioventricular arrangements. The other two views are going to be the short axis view and the long axis view. The short axis view, again coming out of the esophagus, is going to go across the ventricles. It's going to look like this. Here's going to be our thick-walled left ventricle and our thin-walled compliant right ventricle. And then on this we can put our coronary arteries. On the anterior wall, this is going to be our left anterior descending artery. Here's going to be our left circumflex artery. And here's going to be our right coronary artery. And this is important because it allows us to look at the parts of the wall that are going to be perfused. So when we talk about the left anterior, that's going to be roughly the anterior 2/3 of the septum and the anterior wall. The left circumflex, in a non-dominant mode, that's going to be the left lateral wall. And when we talk about the right coronary, it's going to be the posterior 1/3 of the septum and the posterior wall. When we talk about ischemia and what we're going to see in the EKG, if we're going to line up our leads, here would be V1, going over here to V4, and then down here to V6. So that we can see ischemia of the left anterior descending artery is going to give us ST changes in V1 and V2 in the septum, and then V3 and V4 in the anterior wall. Over here in the right coronary artery, this is where we're going to get readings from our leads of 2, 3, and AVF. So those are going to be the leads of inferior wall ischemia. Two other things to look at here is we can do our papillary muscles. Our anterolateral papillary muscle, and then down here, number 2, posteromedial muscle. So imagine now we have ischemia that's going to lead to papillary muscle necrosis. You can see which artery is going to be more vulnerable because the anterolateral has two different blood vessels supplying it, the LAD and the left circ. The posteromedial is dependent on the right coronary artery. 90% of our papillary muscle necrosis in ST elevation myocardial infarction occur in the posteromedial papillary artery. The second view that we do is a much more standard view of the heart. So if we're going to draw our heart here, and again, let's just draw our heart, and here comes our aorta coming out. Here's our esophagus, which is the place we put our ultrasound. Then the commonest view we're going to see is now going to be the long axis view. And this really is our everyday working model of how we think about the heart. We always start by putting in the annulus fibrosus. This is an important part of the cytoskeleton. The valves come off it. It's electrically inert, that drives all the electrical conduction through the AV node and bundle of His, and that's why supraventricular tachycardias don't tend to be life-threatening. Onto this now we can draw our thick-walled left ventricle. Here's our left atrium, and these now become our pulmonary veins. Here's our thin-walled compliant right ventricle. And then here we can draw our right atrium with a superior vena cava and an inferior vena cava. This is a really good way then of thinking about the pump relationship of the heart. The second thing we can do now is we can add in the conducting system. So here becomes our SA node, which goes through the ill-defined tracts to our AV node, which now penetrates the annulus fibrosus through the bundle of His, and then becomes our left bundle, which follows here beneath the endocardium, and our right bundle, again, which is beneath the endocardial cells, and then coming off that for about a third of the thickness, then becomes our Purkinje fibers. So the conducting system is another important way of looking at this view. And then the last thing you can do with this view is you can put on the valve system. So for example, here we can draw our aorta coming out here, and then this would be our aortic valves. Similarly, in here, we can have our mitral valves come in. So doing this standard long axis view is a really important way of thinking through the internal structure of the heart. This is how you're going to do your EKG looking at the conducting system. Because up here, when we start the depolarization in the SA node, this is going to be our P wave. And that long space that it's going to go to the AV node all the way here to the bundle of His, this is going to be our PR segment. This wave of depolarization coming down and out to the Purkinje fibers to the wall is going to be our QRS complex. So when you look at this, you can also think through the conducting system and how it relates to the EKG. A good way to think about the architecture of the heart is to use the short axis view, and you can see here we're going to take this segment, and that's how we're going to model the architecture. And the reason we want to do that is two things. It's a way of understanding the conducting system and a way of seeing the blood supply. Let's take this segment and let's blow it up. So here's my heart here, and here now becomes the coronary artery. In this case, from this view, this would be my left anterior descending artery. And if I was going to draw the pericardium, you can see here, it's subpericardial. This artery is going to come down and it's going to supply through to the thickness. And remember, an artery is a thick wall that has an internal elastic membrane and multiple layers of muscle. The pathology we're thinking of with arteries is going to be atherosclerosis. And we can see now what that's going to look like if we have occlusion of a coronary artery. The most vulnerable area is going to be here, our subendocardium. And there's two reasons for that. The subendocardium is most vulnerable because, one, it has the longest systole. It's the closest to the ventricle, and perfusion only occurs during diastole. So that means it has the least perfusion. Remember as well, it has the longest length before it's supplied by the coronary artery. And the last thing to build into our understanding is, remember, that the heart, even in normal beating, has maximal extraction of oxygen. There's no compensating for deficiency by drawing more of what's passing through. We can see that when we have an ST elevation myocardial infarction, we're going to have unequal necrosis. The subendocardial, this is going to undergo necrosis within 1 to 2 hours of the occlusion. But because of this unequal perfusion, by the time we get to be transmural, that's going to take much longer. You're not going to get necrosis of the subepicardial myocardium for at least 3 to 4 hours. That's why the expression, time is muscle, keys on the fact that the myocardium does not die at an equal rate. This is going to correlate very well with our EKG, because anytime we're dealing with subendocardial phenomenon, in the EKG, this is going to be associated with ST depression. But anytime we're talking about transmural, this is going to be ST elevation. If arteries are atherosclerosis, and as we're going to discuss, atherosclerosis is going to be a disease of thrombosis, giving us occlusion, and that's going to give us angina. What happens when we talk about arterioles? because these are much smaller, about the size of thick threads, coming off all of these arteries, which I'm drawing here in blue. The first thing to recognize when we talk about arteries, it's not a disease of atherosclerosis. This is going to be hyaline arteriolosclerosis. And now we say, well, what's that going to look like if we undergo occlusion? We can see that we're really only going to lose very small amounts of tissue. And so the importance of the fact that these are small amounts explains why 70% of myocardial infarcts are subclinical. They are below the threshold for triggering pain awareness. So how is that going to correlate to our patient presentation if over years to decades we lose 1 to 2 millimeters of tissue in a small time? This is my cardiac function on the y-axis, and I compare that to a time frame which is going to be years to decades. What I'm going to see is this progressive loss of cardiac function. That's eventually going to lead to congestive heart failure. So now we're not talking about a disease of pain, we're talking about a disease which is going to be shortness of breath. So when you look at the tissue architecture of the ventricle and you put the blood supply on it, be very clear in your mind that arteries, atherosclerosis, thrombosis to angina is very different than our arterioles, which is hyaline arteriosclerosis, below pain threshold, presenting over long periods of time with the shortness of breath of congestive heart failure. We also want to use the tissue view to understand how conduction occurs through the wall of the left ventricle. So if we're going to do our short axis view, there's our thick-walled left ventricle, compliant right ventricle, and our coronary arteries. Again, we're going to take this same view, except this time we're going to construct how the myocytes look. So here's our full thickness. This is going to be the chamber of the heart, and there's going to be my coronary artery with my pericardium overlapping it. How then are the cells constructed? Along the endocardium, these are going to be the bundles of our Purkinje cells. These are going to be our automatic cells that conduct. And these cells are going to branch up and connect end to end with the contractile myocytes. They both come from a common myocyte pattern. And you can see that these Purkinje cells are only going to extend about 1/3 of the way through the thickness. They are then going to connect to the branching myocytes. There are 2 types of myocytes, each with a very different function. These conducting myocytes start with the SA node and continue in an end-to-end fashion all the way through to the Purkinje cell. And at the Purkinje cell, they're now going to connect end-to-end with the contractile myocyte. And it's important to note that the time it takes from the SA node all the way through to the Purkinje cell is going to be slow to the bundle of His to give time for the atrial contraction, but from the bundle of His all the way through to the end point, which is the contractile myocyte, that's 0.03 seconds. And then from the time here that it's going to take to go through the contractile system, that's the same amount of time. That's 0.03 seconds. If we take a look at our heart, and let's draw our chamber here, we're going to think that this conducting system, here's the delay here for the atria, this is going to race rapidly at 0.03 seconds, and then it's going to spread out to the myocardium at the same rate of time. And when we take a look at what that looks like, here's our left ventricle here, we can see that it's coming down here through the subendocardial bundles really rapidly, and then these myocytes are conducted in 2 basket-like webs. Because these are all going to suddenly go at the same time, it's going to coordinate to give us a single bolus of heart coming out. In engineering terms, this is called a positive displacement pump. But of course, in medicine, we know this as a stroke volume. And it does that because of this very unique arrangement between the conducting and the contractile myocyte. So that brings us to the end of our discussion for today. You can see that we've started with the regional anatomy, which we think of as the chest X-ray and the CT scan. We then take that to understanding the surface, which is a really good way of doing our coronary arteries. Our internal structures are going to be the 3 views of our echo, T6 for the aortic valve takeoff in the chambers, short axis view for blood supply, long axis view for everything else. And then we've concluded on the tissue level where we've discussed this very specific arrangement between the conducting cells and their tight coordination in time to the contractile cells so that we have this positive displacement pumping action that gives us our stroke volume. In the next lecture, we're going to start again at the tissue, but now we're going to talk about how these cells arrange end to end and how that ultrastructure allows it to have a signal so they know how to contract through the mechanical proteins. So thanks for listening. We'll see you next lecture.